Very much. So we'll move to our final talk for the day. So Dr. Ben Greenberg from UT Southwestern is going to talk to us about when transverse myelitis is not transverse myelitis.
It's my daughter. It's okay. It's nicer to look at her than me. So I want to thank Brenda and the Academy for the invitation to speak today, and it was a great talk by Sean. I will go back. In terms of talking about this issue of diagnostic dilemmas in multiple sclerosis from a slightly different perspective, I've had the distinct honor of being part of this course for a couple of years, and it's an interesting evolution of talks. Brenda does a wonderful job of setting the stage of all the different things that need to be on your radar when talking about demyelinating inflammatory diseases. Dr. Vandiver gives us the scare the crap out of you talk, where you see picture after picture after picture, where I'd say, oh, it looks like a mess, it looks like a mess, and it's not multiple sclerosis, and you get very disheartened on your skills of reviewing brain MRIs. And then we move to Sean, where every year there are more antibodies on his list. His font is getting smaller and smaller to fit all the antibodies in, and there's really no way to keep up with each and every antibody. And those two talks kind of come together in the sense of there are a lot of radiographic mimics of multiple sclerosis. So there are a lot of things on a brain MRI that look like MS but aren't MS. And then within the world of immunology, there are a lot of different autoimmune conditions that can give you changes on the MRI other than multiple sclerosis. I end it with a very different perspective of things, and that is, let's take a syndrome that is pretty classically associated with multiple sclerosis and see how should we in the trenches, how should we in the clinics have a standardized approach for evaluating these patients to cut down on our misdiagnosis rate, because there still is a misdiagnosis rate when it comes to multiple sclerosis. So this slide is supposed to bridge to my disclosures in terms of the different groups I've worked with in different ways. And this is reprinted in your materials. So let's set the stage with a little bit of scary information, and these are the things that we live with day to day in the trenches, taking care of patients when we're considering the diagnosis of multiple sclerosis. What are the challenges? And the first ones become very clear over the last 20 years. Multiple sclerosis is not a disease, it's a syndrome. There are multiple different entities that can give you episodic multifocal demyelination within the central nervous system that are biologically distinct. So even within the people who we accurately diagnose with multiple sclerosis, there are multiple different biologic pathways to get to that phenotype. Hence, you have some patients who are outstanding responders to glutarin or acetate and some people who don't respond. Some people are great responders to interferon or natalizumab, and the list goes on. Because it's a heterogeneous disorder, it opens the doorway to misdiagnosis at a significant level. Many of the signs and symptoms that our patients have with MS can be seen in a multitude of other conditions that are not multiple sclerosis. The imaging findings can be non-specific. So there are the MRIs that I'll put up that even my second-year medical student walking down the hallway will say, that's multiple sclerosis, and they'll be right 9 out of 10 times. And then there are the ones that even the most seasoned MS clinician looks at, scratches their head, and says, it could be migraine, it could be small vessel disease. There are the gray areas, and that's what takes up the majority of our time in the clinic, are the gray areas. The biologic measures of MS are nonspecific. And what are those biologic measures? Well, really the only quantification or qualification of autoimmunity when it comes to multiple sclerosis has been the oligoclonal band testing, or IgG index, or IgG synthesis rate. These are tests that have been around for over 50 years, have been refined over time, but on its basis do not give us a absolutely sensitive or specific demonstration of multiple sclerosis. There are a lot of conditions that can have evidence of intrathecal synthesis of antibodies. Here's where things get tough. So it's a hard diagnosis to make in some or even a lot of patients, but now we've raised the stakes. There is data to suggest that the earlier you treat a patient for multiple sclerosis who actually has the condition, the better they may do over time. And we can talk and debate this fact back and forth, but if you accept that as true, the old notion of, well, let's let time tell us if you have multiple sclerosis is a dangerous step to take if we are missing an opportunity to treat a patient with an appropriate therapy to cause remission of their multiple sclerosis. Likewise, the therapeutic interventions have changed over time such they are riskier to give to patients who don't have multiple sclerosis, not just because of the potential side effects or complications that can occur because of the medications we use, but you may also be missing an opportunity to treat one of the mimics of MS. So the deck is really stacked against us. It's a hard diagnosis to make in some patients, but the accuracy of the diagnosis is critical. So how do we approach this? Well, I get told time and time again, multiple sclerosis is still a clinical diagnosis. And I actually think, to a degree, this may not be as true anymore. The paraclinical testing that is there to support your clinical suspicions is becoming more and more important. And indeed, if you look at the revised criteria over the years, in the most recent 2010 revised McDonald criteria, it still starts with the idea of clinical events. And what's interesting about this table, and this is what I think one of the most misinterpreted tables in all of clinical medicine, is if you have 2 attacks, which means the patient comes in and tells you, Dr. Greenberg, in June I had loss of vision in my left eye and it hurt and it got better, and then the next year I had loss of sensation from the waist down. So these 2 events, and on my exam I see pallor of the optic nerve and I see an upgoing toe on my reflex exam. Technically, they have, quote, met the criteria for multiple sclerosis. And according to this chart, no other additional data is needed. It's not that no other additional data is needed to make the diagnosis. There is no other additional data you need to prove separation in time and space. What's written into the criteria in very small print is you still have to do appropriate testing to rule out mimics. There are lots of conditions that can give you evidence of demyelination separated in time and space other than multiple sclerosis. So you do need additional data and testing to increase the accuracy of your diagnosis. Now, admittedly, these mimics are far rarer than multiple sclerosis. So if in your practice with the patient who comes with that history, you just want to say this is MS, you are going to be right easily 9 times out of 10, probably 98 times out of 100. But it's that 1 or 2% with potentially treatable conditions that give us a lot of consternation. So it's usually at this point that I like to ask the audience, just by a show of hands, do people here have a routine workup? Meaning, every patient that comes to your office, or the vast majority that come to your office where you are highly suspicious of MS, do you have a set number of tests that you do in the blood, spinal fluid, or with MRIs? That no matter what history they give you, you're going to send that test? Just by show of hands, you have a set. So do people here get a B12 level on people you're evaluating for possible multiple sclerosis? How many people here get a B12 level? Let's call it about a half. How many people here get a TSH? How many people here get an ANA on everyone you're considering? Why is my question. So it's interesting, we've gotten into this routine of sending an ANA on all these patients, and I'm guilty too. I'm raising my hand. I get the ANA. And so when the ANA comes back positive, do I tell the patient you have lupus? No, I say you have multiple sclerosis and you're in the 30% of people who have a low positive ANA. It's interesting, we get a lot of tests that don't change our immediate management of the condition, and what I'm going to present to you are 3 cases all centered around transverse myelitis as a presentation to try and spark the conversation about standard workup. So here's the first case. So a 29-year-old woman comes to her internist, week of history, in her hands bilaterally, spread to include her chest and torso. She gets an MRI, and there's a high cervical lesion. Would everyone be comfortable with terming this a partial transverse myelitis and small segment transverse myelitis? Meaning it's less than 3 vertebral segments long, it's not taking up the whole cord, and this is a lesion that's highly associated with demyelinating diseases. I'll tell you, post-contrast, it was enhancing. And you go on to get your standard workup. And here's an example of the workup. You get labs, you have a normal or negative B12, TSH, ANA, double-stranded DNA, anticardiolipin, phospholipid antibodies, ESR, RPR. You tap her. She has the presence of unmatched oligoclonal bands in the spinal fluid. She has an elevated IgG index, 12 white cells. They were all lymphocytes, no neutrophils. Protein was 50. For our lab, that'd be a little elevated. Glucose was normal. Her brain MRI shows multifocal lesions, periventricular lesions. There's a nice ring-enhancing lesion there next to the ventricle. So this is a patient who's clinically presenting with transverse myelitis, who has the testing to try and determine what the cause is. So what do you guys think the diagnosis is? Now, this is a tough question because we're in a course on diagnostic dilemmas in multiple sclerosis. So right now, you're sitting there saying to yourself, he's setting us up, right? You're thinking, well, maybe Dr. Vandergaard, this is a adrenoleukodystrophy. No, damn, it's not that one. You're going through the whole list. So what do we think this is? And just go with your gut. What would you tell this patient? Yeah, multiple sclerosis. This walks like a duck, talks like a duck, looks like MS. I would agree with you. So let's take a look back at this case with the exact same history, and I'm going to take this case the way it actually presented. So same presentation, this MRI, Here's your workup as a reminder in the brain MRI. So on questioning, taking a history, nothing else, you get this information that they've had a dry cough, been diagnosed with asthma on and off over the years, takes an inhaler episodically, it's not a big issue. And you go ahead and you get a chest CT, and there's hyaluradenopathy on the chest CT, you do a transbronchial biopsy, and there's a non-caseating granuloma. And so she gets a diagnosis of sarcoid, and in this case, neurosarcoid. Now, there are some people, and you're happy to take the mic even in the middle of my talk and interrupt me, it's fine, who like the notion of could they have sarcoid and multiple sclerosis simultaneously. I usually don't go that route. I tend to say, let's just pick one diagnosis that could explain everything, and all of her test results, if I go back, can look exactly the same. There's nothing about this that would say it can't be sarcoid. You can have positive oligoclonal bands, you can have a lymphocytic pleocytosis, etc. So a lot of people say, well, what should the workup be when looking for sarcoid? And the top two answers I get is, well, I checked a serum ACE level or even a CSF ACE level. And the problem is, in the literature, this is hard to see, it's in your handout, the sensitivity of the ACE test is atrocious. It's below 30%, meaning you're missing the overwhelming majority of people with sarcoid if you're relying on an ACE test to rule this out. The other thing to recognize is that chest x-rays miss the adenopathy that's seen in sarcoid the majority of the time. And so using a chest x-ray or an ACE test as a screening test for sarcoid is a poor screen. The definition of a screening test is a high sensitivity, so you capture as many people with the condition as possible. When balancing cost and approach and risk and all these other things, in our clinic we use the chest CT, which has probably the most balanced sensitivity for looking for any parenchymal changes, whether they be in the lung or lymphadenopathy, to suggest sarcoid. So let's go back to a case and look at this from a different perspective. And I'm going to give you the exact same history and change just a couple things. So still a 29-year-old woman coming in with the numbness. Here's her spine MRI, that partial small segment transverse myelitis. She still has positive oligoclonal bands. She has lymphocytes, no neutrophils. The protein's 50. And here's her brain MRI. And you go back and you say, okay, this is multiple sclerosis. And indeed, this patient was diagnosed with MS. But then comes back a year later and is quadriplegic and in a severe transverse myelitis. And in this time, the transverse myelitis is not small segment, but actually a longitudinally extensive transverse myelitis. And you say to yourself, geez, this is very unusual for multiple sclerosis. So if we're looking in the adult population, longitudinally extensive transverse myelitis almost never happens in multiple sclerosis, extremely rare. Children in the pediatric population are a different cohort. It is unusual for pediatric multiple sclerosis. When you get to the really little kids, it can happen. But the teenagers and adults, this would be a major red flag against multiple sclerosis. And indeed, you send the blood to Sean, and they do anti-aquaporin 4 testing, and they are seropositive for the NMO IgG or anti-aquaporin 4 IgG. And I was very thankful to Sean's group for their recent publication looking at the notion of partial transverse myelitis and NMO. So if you go to the Winger-Chuck criteria of 2006, which is going to be updated any day now, it talks about longitudinally extensive transverse myelitis as being the pathognomonic feature of neuromyelitis optica. For those of us who take care of a lot of TM and NMO patients, we find a lot of NMO patients have small segment transverse myelitis. And indeed, in this study, when the Mayo Clinic looked at individuals who had a first episode of transverse myelitis and MRIs that proved that it was a short segment TM, they looked back at the individuals who were NMO positive, and if you were a short segment patient and you had this antibody, overwhelmingly you went on to have a phenotype of classic neuromyelitis optica with severe optic neuritis or longitudinally extensive transverse myelitis, and most importantly, you had a phenotype of not responding to MS drugs. So in this case, if I had a patient just like the one I presented to you, so short segment lesion, even with the oligoclonal bands, even with the brain MRI that looks abnormal, which tests would be more practically valuable to you and the patient? Sending an anti-aquaporin 4 antibody or an ANA? The ANA coming back positive most likely is not going to dramatically change your management of the patient. It may trigger more of a workup, it may trigger some thoughts, you may look at their kidneys, you may talk to rheumatology, etc. But a positive anti-aquaporin 4 antibody coming back, even in a short segment transverse myelitis patient, should always take you down the road if the assay was done correctly, and we'll talk about that, down the road of neuromyelitis optica and not starting the patient on a classic MS therapy. So let's talk about the differential diagnosis of transverse myelitis. And this falls into a couple different categories. So when you're faced with a patient with myelopathy, acute to subacute, non-compressive myelopathy, you have to remember that the only explanation is not transverse myelitis. There are non-inflammatory causes of subacute myelopathy that would take you down a very different route. Some of the most common misdiagnoses are vascular causes of subacute myelopathy. These can be dural AV fistulas, AVMs, venous hypertension of the cord. Here, FCE stands for fibrocartilaginous emboli. Is anybody in the audience joining us from Hawaii? Do we have any Hawaii practicing? Whenever we host AAN in Hawaii, we all go there. But when we're in DC, they don't come to us. I understand why. So if you go into an emergency room in Hawaii, so let me ask the question a different way. Has anyone here ever heard of surfer's myelopathy? Yeah, we got 3, and all of you at some point have probably visited Hawaii. If you walk, and we're at the American Academy of Neurology, if you walk into any emergency room in Honolulu and say surfer's myelopathy, every ER doc knows exactly what it is. It's a new surfer who's never been on a board before. They go out, and several hours after they're out surfing, they start becoming paraplegic, and within hours they're totally paraplegic. Their initial MRI is normal. 3 days later, their MRI shows a lower thoracic lumbar central cord syndrome. What's probably happening is as they're sitting on the board prone and waiting for their wave all day because they have no idea what they're doing, they're a new surfer, getting bounced around, they have a break of the cartilage within the venous sinusoids of the vertebral body, and you get a fibrocartilaginous embolus, a venous hypertension event of the cord. And the spinal cord looks just like transverse myelitis. It can be an enhancing lesion of the cord. So not all subacute myelopathy is inflammatory. If you go down the route of inflammation, you then have to look for the different causes of an inflammatory event, most of them being immune-mediated, and those are listed on the left-hand side of the screen. So there's idiopathic transverse myelitis, the definition being the clinician's an idiot, the patient's pathetic. Idiopathic. We don't find the cause of transverse myelitis. Multiple sclerosis can present with TM, obviously neuromyelitis optica. We've talked about sarcoid. This can be a manifestation of both lupus and Sjogren's, which should be considered. Infectious myelitis is considered historically to be exceedingly rare, and I'm going to challenge that at the end of the talk and see if we should still consider it exceedingly rare. So when you have the patient who presents with transverse myelitis and you're thinking about this long list, what should your standard workup be? And what I'm going to do is present a framework for considering a standard workup based on 2 things, taking a history and looking at the MRI. And based on what you hear in the history and what you see on the MRI would dictate what accessory tests you should do in terms of how far should you challenge the diagnosis and how often should you think of multiple sclerosis. Let's take this out of order and talk about radiographically first. So it turns out there's a lot of different ways your spinal cord can be impacted by an inflammatory event, and I'm restricting this not just to inflammation. We'll talk about non-inflammatory and inflammatory etiologies. But you can have spinal cord changes on MRI that are predominantly gray matter. You can have what's been described in the literature as partial TM, meaning in the ventral dorsal distribution of the cord, it doesn't take up the entire cord. Longitudinally extensive TM is defined as 3 vertebral segments or longer. You can look for other findings, such as meningeal enhancement around the lesion, outside of the cord, extraaxial enhancement, and you can look for central cord syndromes. What would this cause you to think of? And that's listed here. I'm going to revisit the issue of the gray matter in a moment, but when we look at partial TM, it's important to note that you can see this in MS, and that's the classic presentation, but it is not the only disease that presents with partial TM. You still have to consider neurosarcoid, neuromyelitis optica, even lupus and Sjogren's in these patients with partial transverse myelitis. But the reverse holds true pretty well. The longitudinally extensive patients are almost never multiple sclerosis. You really should look for non-MS diagnoses, even if your brain MRI looks like MS. Even if you have oligoclonal bands in the spinal fluid, you have to consider other diagnoses. Meningeal involvement is usually a very big tip-off for sarcoid. If we see meningeal enhancement around the myelitis, we will consider gallium scans, PET scans, looking for any evidence of sarcoid anywhere in the body because it's a major red flag. Central cord syndromes have been defined and described quite nicely in neuromyelitis optica, but it is also commonly seen in non-inflammatory causes of myelopathy, specifically the vascular events. And so these are patients in whom you would have a high suspicion and consider getting a spinal angiogram. So let's talk about transverse myelitis the way I was taught to think about it and all the ways that I was taught wrong. So if you were one of my teachers, take note. So I was taught this, that transverse myelitis is a white matter disease, that this is infiltrating lymphocytes into the white matter of the spinal cord, causing demyelination. And this, I would assume, everyone in the room, this has been the description of transverse myelitis that you've heard. Even in papers that I have authored about transverse myelitis, the first or second sentence usually says, this is an inflammatory demyelinating disorder. I now have to strike that sentence from the papers because it turns out there are different patterns. And I'm going to show you some of the patterns we've seen when we really start to study myelitis. So the first is a white matter restricted pattern. So the classic presentation for multiple sclerosis where you have that young woman coming in with sensory loss and a dorsal column restricted partial myelitis, and you haven't even looked at the brain MRI or the spinal fluid, but deep in your gut you know, geez, there's a good chance that this is multiple sclerosis. That's the white matter restricted. Here's an example of the central cord phenomenon, which you can see on the right, the T2 hyperintensity on the right. This is what we see in neuromyelitis optica, even when it's a partial TM, so this can be a small segment central cord. We see that a lot with neuromyelitis optica, or you can see it with vascular events. Can you see this in MS? Yes, you can, but it definitely raises a flag to look for other condition. Then we're starting to notice this a lot more when we look, especially in our pediatric population, mixed and gray matter involvement, where you get the anterior horns as a T2 hyperintensity and then spilling over into the anterior cord. And then in some cases, especially in some kids, you have restricted T2 hyperintensity to just the gray matter. There is no white matter involvement. Now, in all of these conditions, there is evidence, and I won't go through those studies yet, to suggest that there's an inflammatory component to each of these patterns. So by definition, this is myelitis. This is spinal cord inflammation, but we're getting very different antigenic targets. The reason Sean's presentation is so much better than my presentation is he's figured out all the antigens for his antibodies. So he can show you this one's intracellular, this one's extracellular, this one's hippocampus, this is cerebellum. I'm not that good yet. I'm still at the MRI level of sorting out white matter versus gray matter and then going after the specific etiologies. But when we looked back at a cohort of pediatric patients within our center, and we're doing this in adults as well, one of the statistics that I found staggering was anywhere from 20 to 50% of our patients had some version of gray matter involvement. So I was taught transverse myelitis is a white matter disease. I was wrong about half the time. That's a lot of the time to be wrong. And it has implications both in terms of etiology and in terms of treatment. What else should you do besides looking at the MRI for a transverse myelitis patient? Well, turns out we should talk to our patients and still do an exam because we are looking for evidence of either through history or physical of some other feature that would give us a hint about etiology. So for example, if your patient gives you a history either symptomatically or through testing, maybe you do visual acuity testing, or you actually look in the fundus and see pallor, or get optical coherence tomography and see a thinning RNFL, you find evidence of optic neuritis, that should be a flag. If the patient gives you a history of nausea, vomiting, or hiccups, that should be a flag. As we saw in one earlier case, pulmonary symptoms, even as mild as asthma or chronic cough, should be a flag, etc. And here are the etiologies that these different historical facts would make you think of. Optic neuritis does not discriminate between MS and NMO. So the original descriptions of NMO having severe bilateral optic neuritis, it's true, they can have that, but in fact the majority of my NMO patients will have mild unilateral optic neuritis. And so just because somebody's optic neuritis was mild does not allow you to bet on multiple sclerosis as the etiology. Nausea, vomiting, and I left off hiccups, and that's my mistake. Hiccups should be listed there as well. Going through residency, when I was doing my review of systems, I hardly ever asked about nausea, vomiting, hiccups. Every single patient who's coming to me now as a new evaluation, I ask the question, have you ever had intractable nausea, vomiting, or hiccups? And when you ask, it's amazing. It is about 15 to 20% of my patients, and with that, who ultimately have NMO, will endorse at some point a, quote, gastritis that they were in the ER for a few years ago that never went away. Pulmonary symptoms, obviously, for sarcoid, systemic symptoms, dry eyes, dry mouth, joint pains make you think about mixed connective tissue disorders, and pain at onset is a non-discriminatory factor. We see this in NMO, you can see it in sarcoid, vascular events, multiple sclerosis, they can all have pain at onset. So what should we do in terms of testing besides looking at the MRI and the history? Well, the spinal fluid can be helpful, but there is nothing in the spinal fluid that once you confirm myelitis will tell you what's the cause, NMO, sarcoid, or MS, with a couple exceptions. You're going to test the cell count, you're going to look at the differential, and that turns out to be critical. The protein, you're going to look for evidence of oligoclonal bands or an index. The IgG index and the oligoclonal bands, which have most classically been described as associated with multiple sclerosis, are not specific in any way, shape, or form. They can be seen in sarcoid, they can be seen in neuromyelitis optica. I use them to determine, is the etiology I am witnessing autoimmune or not? So it gives you a sense if the immune system is activated. So migraineurs should not have oligoclonal bands in their CSF. So if you're trying to decide if this is vascular, migraine, or one of these diseases, the oligoclonal bands can be helpful. But what about the CSF profiles in transverse myelitis? In multiple sclerosis, the majority of the time, the cell counts is going to be in the single digits or low double digits. It is rarely above 50, even though the range here is 0 to 92. 50 and above should always be a red flag relative to multiple sclerosis. And you should really only see lymphocytes and monocytes. If your differential ever includes granulocytes and it's not a bloody tap, you should think of etiologies other than multiple sclerosis. Oligoclonal bands, depending on who is reading the test, can be positive in 50 to 90% of patients. In neuromyelitis optica, cell counts tend to be higher, so when you get to that 50 and over, you tend to want to think about NMO or sarcoid. And the other tip-off would be if you had neutrophils present. But as you notice at the bottom, the difference between NMO and sarcoid can be really difficult. Both of them can have high cell counts, both of them can have neutrophils. So while the presence of neutrophils or a high cell count can get you out of the MS category, it does not give you a specific diagnosis. So after all of this, is there actually a standard workup for transverse myelitis? So there are guidelines that came out by the American Academy of Neurology, published in Neurology about 4 years ago, 3.5 years ago, looking at different tests that you could order. And the language was as such, that aquaporin 4 antibodies are probably useful to establish the cause of TM. I think that's an understatement, but it is accurate based on the literature that was available at that time. I think in today's world we would say that it's a very appropriate test to order on any patient with transverse myelitis, regardless of length of lesion. There was only one class 3 study looking at pleocytosis in terms of being a discriminator, and oligoclonal bands were possibly useful for looking at MS, and I think that's the appropriate language. They are possibly useful, but not always accurate. So let's move into how you would do a standardized workup. Should we all be ordering ANAs, B12s, thyroids, or should we streamline our workup? And unfortunately, for you to decide what a standard workup should be for transverse myelitis, we have to shift gears to some statistics. And this is usually late in the day. You've been sitting here for hours. This is usually where I push people over the edge to either being suicidal or glazed over. So I'll try and keep it as pertinent as possible. But there's going to be a few slides with numbers on them. So you have tests that are offered, and I'm going to walk you through the classic way you think about testing and the way I think you should think about testing. And so let's say, and this could be oligoclonal bands. You can pick any of these tests, aquaporin 4 antibodies, whatever you want to plug in here, but it is test X. And you study to determine how useful it is. If we were talking about the last talk, Dr. Pittock's talk, how useful is an NMDA receptor antibody in this patient of cohorts to give you an accurate diagnosis? And so you run the test on a group of patients, and sometimes you get false positives, sometimes you get false negatives. There is no 100% perfect test in medicine at all. There's not a single one. Even biopsies have a sensitivity and specificity. So there are misread or misinterpreted or missampled or mishandled biopsies. So there is nothing with 100% sensitivity and specificity. And what happens is something like this. Out of the people who have the condition, 100 out of the 110 actually test positive. And for those who don't have the condition, you had 20 false positives. And most of us in the room are used to reading these numbers, and we report these numbers in the literature as sensitivity and specificity of assays. And what I would say, and we've been taught that a negative result from a high sensitivity test essentially rules out the condition, a positive result from a high specificity test essentially rules in the condition. This is not a very useful way of presenting the numbers in an actual clinical practice in the trenches. This is great from a public health perspective, but if I were to ask anybody in the room, even people who spend a lot of time with this, To take these numbers and to take a patient and have this impact your clinical care, it's actually pretty common for practicing physicians to misinterpret the value of sensitivity and specificity. The real number that we should be using in clinic are what are referred to as likelihood ratios, and this is usually where I lose everybody, but I'm going to put it into practice for you. So a likelihood ratio uses the sensitivity and specificity to say, if you have a patient population X, if you have Margie Jones walking into your office with a certain set of symptoms and you send a certain test, how likely is that, if it's positive, how likely is it that the person actually has the disease? Did it change the way you thought about this individual? And like there is a likelihood ratio for being positive, there's one for being negative. And let me put it into practice, and I promise these are the last number slides. So on the left are listed sensitivities and specificities, and I'm going to give you a magic number for likelihood ratio positive. The magic number is 5. So if you have a likelihood ratio of 5 or higher, that test is helpful to you in the clinic when it comes back positive. So if you have, so let's find an example. If I said to you, if I publish a paper today and I said, this test is 95% sensitive and 80% specific, that sounds on its face like pretty good. I'd buy that test. I would send that test on patients. But the likelihood ratio on the positive side is below 5. In fact, it really doesn't change the practice as much, and I'll show you why that's the case in a second. Likewise, so for likelihood ratio positive, 5 is the magic number. For negative, the magic number is 0.2 or lower. So let's pick an example here. And an example here would be a test that was 80% sensitive and 90% specific. Again, on its face values, that's going to get published in Neurology or JAMA Neurology or Annals. It's a well-documented test that may have merit, but if you test negative on that test, in actuality, it may not change your practice that much. And let's put this into effect. So I'm going to show you 2 slides. Those are done, no more numbers, at least I'll talk about numbers, but we're not going to do any more math. Let's put this into practice. So what you see on this graph is pre-test versus post-test probability, and let me define that. Pre-test probability is very simple. It's your inner gestalt. I was having a conversation with Dr. Gudesblatt about this earlier today. So I'm going to prove to you what pretest probability is. Ready? Here we go. A 29-year-old Scandinavian, blonde-haired, blue-eyed woman who has a multi-generational family of multiple sclerosis patients comes to you with 2 weeks of numbness below the waist and reports that a year ago she had loss of vision in the right eye, and 2 years before that she had weakness of her right arm. What is your pretest probability that this person has multiple sclerosis? So you're listening to the history. You haven't even examined the patient. Your internal barometer is screaming multiple sclerosis. And then I add on, the brain MRI shows multifocal periventricular white matter lesions. She has oligoclonal bands in her spinal fluid with 10 lymphocytes. Your pretest probability is off the charts, right? So you would, on the bottom, go, I am 90+% sure. You may even be 100% sure that this person has multiple sclerosis. And then you order a test that was 90% sensitive and 90% specific. What would a negative test do to your thinking, or a positive test? So in a 90% sensitive and specific test, which is pretty good, you have a likelihood ratio positive of 9, so you're past that 5 mark, and a negative of 0.1, so you're below that 0.2 mark. As you get into the 50-50 range of pretest probability, a positive test seals the deal for you, a negative test tells you to seek other diagnoses. So that point, that 90% sensitive specific, the likelihood ratio of 9 and 0.1 makes a big difference. And this shows you, and this pointer's not working. Let me see if I have another one. So what this shows you is with this pre-test and post-test probability, this gray line is nothing. Each of these lines are a likelihood ratio getting higher. So this is a likelihood ratio of 2. This is a 5. So let's take a situation where you were 50-50. I don't know if this patient has MS or not. It's definitely on my differential. And you get a test that has a likelihood ratio of 2. It only moves you in the 60 to 70% range. It doesn't make a big difference. Whereas once you get to likelihood ratio of 5 or higher, you can be pretty convinced that that person has the condition. Overwhelmingly, 4 out of 5, 9 out of 10 times, the patient's going to have the condition. As you move to likelihood ratios that are 2, it doesn't matter where you are in this curve, it really doesn't make a difference for you. So determining the likelihood ratios relative to these tests makes a difference in which test you order. So when you apply that to what we do, let's look at the tests you've ordered and how well do they operate. So how many people here with a transverse myelitis patient would order a brain MRI and look for multifocal white matter lesions to determine MS? I know I do it all the time. How good is it? Well, there are lots of different studies looking at the brain MRI for sensitivity and specificity of MS. And I love these studies. These are my favorite studies in the entire world because we read through them very quickly, but we miss the most important part about these studies, and that was which patients were entered. Most of the studies that report a high sensitivity and specificity, which are here in white, are case control studies. So I take 100 patients with proven multiple sclerosis and 100 patients with proven sarcoid, and I look at a certain criteria, and I can differentiate between the two. I haven't had a single patient walk into clinic with the label on them, I have sarcoid. That hasn't happened to me yet. And so what I have are cohort studies. I have patients coming to me where we don't know what they have, and we have to follow them out over time. And indeed, when you do cohort studies and you apply different criteria for the MRI, the sensitivity and specificity of the criteria drop dramatically. Because now we're in the real world. Now we're in the trenches where things are dirty. Now we've got these NMO patients that have multifocal white matter lesions. Now we've got metachromatic leukodystrophy coming into my clinic, which I'm never looking for, but episodically will rear its head, and I'll say, damn, I missed that one. And so the sensitivity and specificity changes with the cohort study. And indeed, when you look at sensitivity and specificity for even up through the 2001 McDonald criteria, depending on where you are in the history, these two red bars are the difference between doing a scan 3 months in versus a year in. Your sensitivity and specificity changes based on how much history you have on the patient, because you weed people out. They declare themselves as having NMO, or they declare themselves as having sarcoid. So the sensitivity and specificity of the MRI is not all it is cracked up to be. It's in the 80s. What about oligoclonal bands? Unfortunately, they don't fare much better. Oligoclonal bands are very dependent, the sensitivity and specificity are very dependent on who's doing it. Most of the studies done in research labs for oligoclonal band testing report a very high sensitivity and specificity. But the same issue applies. We got 100 people with known MS, 100 people with known neuromyelitis optica, and they separate out. In oligoclonal band testing, depending on who reads the test and how they do the test, will dictate how accurate it is at picking up on intrathecal synthesis of antibodies. And then we move to a test like aquaporin 4. Well, the aquaporin 4 assay, the sensitivity, specificity, and likelihood ratio changes on what type of test you do. And Sean alluded to this briefly in his talk. But for those of us who are getting the test done at commercial labs, Quest, LabCorp, ARUP, Athena, they are using the ELISA assay. Turns out that the ELISA assay has a certain false positive rate that a cell-based assay does not have. So you'll get back from any of the commercial labs NMO antibody positive with a low level positivity. It's actually quite likely to be a false positive. Their cutoff has too high a sensitivity, so you get a lot of people coming back as positive. So depending on which assay you order, where you send your blood, can dictate how you incorporate that positive or negative result into your decision to diagnose and treat the patient. And I'll end with the ACE level, looking at sensitivity and specificity. What gets quoted to me all the time is this: 75% sensitive, 80+% specific. That is referring to pulmonary sarcoid. People with active pulmonary sarcoid very commonly have an elevated ACE level. Individuals with neurosarcoid, way more often than not, have a normal ACE level. And it is also possible to have an elevated ACE level in other conditions. It is neither sensitive nor 100% specific for sarcoid, except in the CSF. If you had a dramatically elevated CSF ACE, the specificity is high enough, but a negative ACE does not help you. So here would be, it comes to the end of a proposed diagnostic workup to catch these mimics of multiple sclerosis when talking about transverse myelitis patients. I think they all do need a brain MRI. I think even though nothing's 100% specific or sensitive, it definitely helps weed things out. I do tap these patients. I'm looking at how many cells they have and what the differential is. I am looking for oligoclonal bands. As a test to see if they're negative, should I think about non-autoimmune conditions? I send an anti-aquaporin 4 antibody on every patient who I'm evaluating for demyelinating disease, regardless of the phenotype, and Mayo Clinic has yet to send me any residuals or kickbacks for all of that testing. I'm still waiting. I get a chest CT on all patients in whom I'm considering a diagnosis of multiple sclerosis. I'm an outlier. There is no standard recommendation for this whatsoever, but based on the lack of sensitivity for the ACE test and the chest x-ray, I have found this to be the best test I have to check for evidence of any systemic sarcoid. I do look at the SSA, SSB, and ANA to look for mixed connective tissue disorders, but these are extremely low yield. I send a copper on patients with what looks like transverse myelitis because we do pick up on probably about 1 copper deficiency per year, usually older patients, but we can find it. And then in certain cases, spinal angiograms to look for mimics of TM that have nothing to do with multiple sclerosis. So with that in mind, I like to remind everybody that not all myelopathy is inflammatory. There are non-inflammatory causes of myelopathy. Inflammatory myelopathy is definitely treatable. You want to make the diagnosis accurately and quickly. And there aren't large-scale studies for the diagnostic algorithms, but certain tests definitely have therapeutic implications. And with that, I am happy to take any questions. And I think we're moving to a big question session. But yes.
I thought that was a great talk, but there's a couple things. First of all, angiography is a big deal, and I would have really put a big star next to that in terms of doing it. There's some features of sarcoid, imaging-wise, that tip you to sarcoid. Meningeal enhancement on a spinal cord MRI is a big deal, and that I would look very carefully for that. And also the lesion position in the brain. They're bigger, they're sometimes thalamic, they're not exactly where you showed. That scan that you showed, given what you said, has 2 diseases, in my opinion, sarcoid and MS. The scan that you showed.
Right.
One other thought I had. B12 deficiency would be something, obviously we can tell that, but B12 produces a spinal cord image very similar to all of them, and I think I would include that in my list because it can produce long segments that are dorsal column. And finally, your attempts to anatomically localize a lesion to the horn cell on an MRI is pretty brazen because as good as we are at this, a lot of lesions, the ventral horn cell doesn't occupy that much space. And a lot of lesions that are, for example, big lesions in MS, whether they be NMO or MS, you can't really tell exactly where they are. They kind of look like they're white matter, but they kind of spill into the motor neuron. So I think to talk about a gray matter lesion in the cord is a difficult thing. But I thought your talk was great.
I appreciate it in the comments, and I'll pull out 2 of them just to expand on. So I think you're right. In the overwhelming majority of MRIs, the differentiation of gray and white matter is extremely difficult. Some of the images shown here are when we've done more advanced imaging to really do the segregation and isn't as accessible in an average clinically acquired scan. I will say, though, there are circumstances, even on a 1.5 Tesla from anywhere, where you can clearly see the gray matter restricted T2 hyperintensity. And we didn't get to go into it today, but there is more so in pediatrics than adults this issue of acute flaccid myelitis, what we saw over the last year with kids becoming paraplegic. And a lot of them would come in with the mixed picture, where it was very clear on one segment that all I saw was gray matter. And as you moved rostrocaudally in the cord, then it expanded to some white matter and gray and back and forth. And so I think that part's an evolving story. The other comment I'll make on angiography, you're right about a big star, but my big star next to angiography is going to be different than yours. So angiography is a moderate deal, depending on who's doing it and where it's happening. It is a big dye load, and there's a lot of radiation exposure because it's basically fluoroscopy doing it. Depending on your situation, the rapidity of onset and the pattern on the MRI, if in your gut, your pretest probability for a vascular event is more than 20%, let's say, like it's a legitimate differential, you need to be aggressive with your radiologist. They will look you in the eye and swear to you that the MRI is good enough, or an MRA or a CTA, and in my experience, they are not appropriate screening tests. And so we just get pushback. Yeah.
You're right about that. The picture you showed of the 2 dots in the axis
Yes.
plane, snake eyes, That is usually a myelomalacia scan. I don't know. I didn't look to your sagittal. I couldn't see it, but you called that a gray matter scan. That thing is a classic description of
that was 72 hours into a clinical syndrome.
That's unusual.
That's exactly
typical for damage.
That's my point, and that was a pediatric patient specifically. I don't know who was next. Yeah, we can alternate sides. Yeah.
Hi. I just was wondering if you had any comments on persistent enhancement of cord lesions, because I recently inherited a patient about a year ago who sounded like they presented with a classic MS presentation, and the original scan had an enhancing brain lesion and 2 enhancing cord lesions. And when I picked up the patient, he hadn't had a scan in a while. I repeated a brain and a cervical scan, and he had an enhancing lesion at, I think it was C4. Normal exam, no symptoms, and maybe I should have, but I didn't think much of it. A year later, I had switched his therapy for other reasons. He didn't want to inject anymore and other things. And then a year later, I repeated the scan, sort of routine surveillance, and realized the same cervical lesion was still enhancing. So I showed the scan to radiology and neurosurgery, and everybody swore up and down it's demyelinating.
Right.
And so I'm planning to work him up for sarcoid, but I was wondering what other thoughts you had.
Yeah, it's a great question, and there's 3 parts to my answer. So one is we have no serial scan studies in myelitis from any etiology on average time to resolution of the inflammation. In multiple sclerosis, there's actually a nice study that indicated about 15% of lesions will persist in enhancement for even 6 to 12 months. So at least in MS, we know that it's possible.
I left something out, I'm sorry. I was able to get my hands on an old report from 2009 that described it was one of the 2 lesions was in the same location, but he's supposed to bring me that scan.
Right. So the next 2 parts of the answer are, number 1, persistent enhancement. More often I see in sarcoid and NMO than I do in multiple sclerosis. So that's the short version. The third is, and I'll make this brief, that one of the last patients I saw in clinic before coming to AAN was a woman sent to me who had had transverse myelitis 6 years earlier, enhancing partial lesion in the cervical cord, subacute onset, was diagnosed with multiple sclerosis, had a couple small deep white matter lesions in the brain, started on interferon, and her symptoms kept fluctuating, but they were always kind of the same symptoms fluctuating, but they were called exacerbations, and she'd get steroids and different things. She moved to Tysabri, she converted to JC positive, then somebody said, you're breaking through all these diseases, maybe this is NMO. They gave her Rituxan, and she came up to see me for a second opinion about management of NMO. I put up her scan, and it was for 6 years the exact same enhancing lesion in the central cord with cord expansion. She had an ependymoma. And so sent her to neurosurgery, and she's got an ependymoma, and they have to wait for her B cells to come up to decide what to do about it. So we always cautious about these persistent enhancing lesions. If we're convinced it's inflammatory, which is the first step, and not a venous anomaly, a venous angioma, a tumor, anything like that, sarcoid and NMO, in my experience, no data, tend to persist longer than MS. Yeah.
Thank you.
Chris Oakes from London. A couple of points about bands in the CSF. It's often said that if you don't have bands in the CSF after about 3 years, you probably don't have MS. That's one point. And if you do have bands in NMO, as you did mention, it's said that they become negative after a few months. What's your take on that?
Yeah, my take is I have seen the same literature and statistics reported to me, and I always end those sentences with, it depends. And one of the major things in my world it depends on is where the test is being performed and who's performing it. And so one of the days that I lost my faith in oligoclonal band testing was when patient was tapped, and by accident, 2 tubes were sent in different bags from the exact same tap on the exact same patient to be tested for oligoclonal band testing. So the exact same sample got tested twice. And I got back a report that said 0 oligoclonal bands and a report that said 5 oligoclonal bands from the exact same patient, the exact same sample. And I called the lab, and I just said, would you mind pulling the accession number? So they pulled the scan. I said, how many bands do you see? They said, we see 5. I said, great, can you pull this other accession number? They pulled it. I said, oh, this is a negative test. I said, well, it's the exact same patient on the same day. And so it is a subjective test on who's reading it on a day. And so I think there is some movement, positive to negative. I have not been necessarily convinced on how to segregate that with NMO. I agree that the data for MS suggests that once you're positive, it persists. And in my experience, that's the case. I do not have an MS patient. I don't have one. I don't know if anyone else does, who was positive at one point and negative on band testing later. I can't think of an example of that. I don't know what to do with the NMO going back and forth.
That was an excellent talk. Just wanted to put a plug in for checking a SED rate. It's a fast, cheap test, and if your SED rate is 100, it's probably not multiple sclerosis.
Yeah, so in ESR, I've had it go both ways. I think it's a fair, as a screening test, and we're talking about in the world of screening, to make you think about other things. In transverse myelitis, we really don't see vasculitis of the cord. I haven't had a cord vasculitis. I've had, of the cord. And so it's one of those things where it can be driven up, though, by so many other things that if I got back an ESR of 100, I'd be searching for a lot of things. I think it's a fair screening test to do. I'm not sure it would take me down one direction or the other.
What about Bahjat disease? I know it is a clinical, Bahjat is a clinical diagnosis, but if the patient developed uveitis, pars planitis, as a first presentation of multiple sclerosis.
Yeah.
Yeah.
I think you raise a great point with Behçet's, and I would put that in, and I think it's a fair edit for the slide on history taking to do. So I had listed optic neuritis. I didn't list uveitis, pathergy, or some of the other findings, ulcerations that you can see with Behçet's, and this would be part of the questions that we ask. I think one of the things about uveitis, though, is there are MS patients who can develop uveitis as well. And so it doesn't necessarily discriminate.
And can these two diseases occur together in the same patient?
Can these two diseases occur at the same time in the same patient? It gets to the same as sarcoid and MS at the same time, or Behçet's and MS. I'm a simple country doctor, and so I like to explain things one way unless Sean can show me the two antibodies simultaneously. So in general, I say it's possible, but if one of the two conditions requires immunosuppression, the nice thing is MS is treated with immunosuppression, so I tend to pull that off the shelf and treat it that way. And Dr. Shees.
Excellent talk. Thank you very much. You mentioned that you routinely send copper on your TM patients. Now, are you doing that even when MRI shows expansion beyond the dorsal columns?
Yeah, so it's a good question. So copper testing, I am doing it on everyone because we do have cases even with beyond dorsal column T2 signal change. So, yeah. Yes.
What is the significance of positive oligoclonal bands when MRI of brain and spine is normal?
Say that one last part. Positive oligoclonal bands when MRI is?
When MRI is normal.
So a transverse myelitis patient with a normal brain MRI and oligoclonal bands present, there's about is that the situation you're describing?
No, it's not a transverse myelitis patient. It's the patient who did a TAP for some other reasons. And
okay.
So just come with positive oligoclonal band, but everything else is normal.
Okay, so this is a great question because what you're defining is I can't answer that unless we know the clinical scenario because that sets your pretest probability. So my answer for your question would be one answer for transverse myelitis, it would be different for seizures. And so depending on what prompted the test interprets or determines how you interpret the result of the test.
This is a patient presented with external ophthalmoplegia.
Okay, so a patient with external ophthalmoplegia, normal workup, you have oligoclonal bands, it's usually when I'm calling Sean and saying, I have a patient with this deficit, evidence of autoimmunity. The oligoclonal band testing just says, call Sean's lab. That's just, they should just put his phone number at the bottom of the test because it puts us into the autoimmune world, but not in one of these classic syndromic scenarios. So I'd be looking for an antibody-mediated condition. Yes.
I was just wondering if you could think about what would be the most specific test to rule out a diagnosis of sarcoidosis. I'm thinking specifically about patients that you see with optic neuritis, partial transverse myelitis. You suspect this person has sarcoid, they have a high serum ACE level. You do your CT chest, nothing shows. Do you do your gallium scan? When do you stop? Do you repeat the tests?
Yeah. We run into this situation a lot where we have evidence of CNS inflammation, a positive ACE, but no other evidence of sarcoid. The sensitivity of the ACE is relatively low. The false positive rate is not zero, so you can have false positives, but it's not as big an issue as the sensitivity. So in general, we tend to lean towards managing as sarcoid. And one strategy that we have used is if they were coming in close to their active event, they had been treated with steroids, and we were making a decision, we would manage them as neurosarcoid, which in our clinic means some sort of immunosuppression for about 2 to 5 years, and then wean off the immunosuppression, because the majority of sarcoid patients will stay in remission after that, not all. But then about 6 months later, do a gallium scan. Start to see, are they having inflammation somewhere, to try and follow them up and see if it is sarcoid. But it is a tough situation. So. And I think last question.
Yeah, sure. I think you commented earlier. Do you just want to comment briefly on possible viral etiology of transverse myelitis? I mean, again, you have a history and you have CSF results, and it will drive you in one direction or another, but is there a population statistic for something like that?
Yeah, so viral etiologies of myelitis. So I think there are viral causes of myelitis, and what we are trying to sort out is it direct infection of the cord, or similar to the HSV NMDA story that Sean was referring to, are there viral illnesses that then trigger an immune response to the cord? In the first type, direct viral infections of the cord, we're highly suspicious this last year and in years past that there may be an enteroviral associated myelitis syndrome. This is the ones that have gray matter involvement, more common in kids than adults. We have not yet proven conclusively that it's direct viral infection of the cord. And the important thing that I would take away in all of this is, even if you think there is a viral infection of the cord, you do not have to withhold anti-inflammatory treatments. In pretty much every CNS infection, it's true in herpes, which is a pretty classic, just massive brain infection, that even patients who get steroids not only probably aren't harmed by the steroid, but in fact a lot of them do better, because some of the insult to the CNS is with the inflammation that's fighting off the infection. So even if you suspect it, I think you're fine to treat this as an autoimmune condition. We do not know the statistics, though, in terms of percent breakdown of these cases.
A comment on that as well. You left off the great imitator, which is not syphilis, but which is VZV, which absolutely can cause myelitis.
Yeah, so VZV and Don Gilden from Colorado has probably done the most work on this and has been a leader in this field in terms of two versions. So there is VZV involvement of the cord in the setting of a zoster outbreak, so a shingles outbreak, where you can get, with the herpetic lesions of the skin at that dermatome in the cord, you can sometimes see inflammation changes in the root of the cord. But then there is also this condition of the synherpete, the myelitis synherpete, where there's a suspicion that VZV is involved. And the evidence for most of the evidence of this comes out of increased VZV IgG indices in the spinal fluid compared to the blood, evidence that there is a specific anti-VZV immune response happening. I think it's a very rare presentation of myelitis. I don't think it's zero. But again, even in those cases, and I've had a couple of them, where we treated them as just a classic, without acyclovir, a classic transverse myelitis, they got better. And so it's only in one where we really had to pound them with acyclovir to turn the corner. But it should be on the radar.
So just to remind you, if you have questions for any of us, you can feel free to ask. While you're thinking of those, I just want a quick show of hands. When we started this course a few years ago, we had a 5th session where we presented a random series of patient-related vignettes and kind of got you engaged to help us work through the differential, scattering them without any way for you to figure out which we were going to be doing, since we would mix them up amongst each other. Can I have a quick show of hands? How many of you would have preferred, instead of this interactive stage, that we put in those sort of 5 or 6 case vignette ending to challenge you with different cases? Can I have a show of hands if you'd prefer the case vignette format? Okay, all right, so we'll definitely do that for next year. I would ask you, you have my email, I believe, in your book, you should have. And certainly all of us are listed on the AN as well. If you have patient vignettes you'd like to have included in next year's course, please email me and we'll collect a series of them to illustrate key points. So with that note, I'd also like to see if there's any other questions that people would like to ask at this stage. Please go ahead, and then I will share with you a couple of questions I've received in the break that I think the group might find interesting. Go ahead.
I have a question regarding the antibody-mediated encephalopathies. If you do a spinal tap in those people, do you see IgG index or abnormal protein synthesis?
Do you see IgG or oligoclonal bands in antibodies?
I don't know, this microphone is on or
yeah,
not.
so the answer is yes, very commonly. Just recently, we're developing a new mass spec way of looking at oligoclonal bands to replace the old way of looking at gels. And so in doing that, we're actually currently looking at oligoclonal banding. So I can tell you that I looked at about 15 patients where we had matched CSF and serum and NMDA receptor encephalitis, and about a quarter of the patients are positive for oligoclonal bands, and some of them have up to 12 CSF-specific bands. The same is true for pretty much all of the both paraneoplastic and autoimmune neurologic disease. So oligoclonal bands are very, very common. Elevations in IgG index and synthesis rate are also seen, but are not as common as you see in MS. But you do see patients with elevation in IgG index and synthesis rate. But the oligoclonal bands are the most commonly seen abnormality.
My other question is, if you can't rely on the oligoclonal bands, can you rely on the IgG index?
Do you mean
regarding MS?
Are you talking about specificity for MS?
Well, because he said that oligoclonal bands can be not reliable. So would the IgG index be more reliable to
No, I don't think so. So for me, unfortunately, I had to step out for a few moments there because my fellow was presenting in another room.
Yeah.
So the oligoclonal bands are not specific for any inflammatory CNS disorder.
Right.
IgG index also is not specific either. So you can see those with a multitude of different disorders. They can be helpful in maybe I missed that, but Ben might have been talking about the ability, if you have a CIS and you have oligoclonal bands, it is helpful in the sense that it may be predictive of the development of another attack, and that's been shown recently in pediatric cases. But these things, we have to be very careful. They're really not specific. So oligoclonal bands, for me, are the same as again, and I come back to this, the concept of just looking at the patient clinically. Yeah. If a patient has vitiligo, that means as much to me as an oligoclonal band in the CSF. It just tells me that the condition may be autoimmune.
Yeah. So in the context of when we're talking about assay specifics, when we've looked at this data internally, there's a subset of patients who have discordant oligoclonal band testing and IgG index. So where you have a positive oligoclonal band and negative IgG index, and some where the reverse is true. The IgG index is positive and the oligoclonal band is negative. I have yet to find that be, I lump them together and I put an or statement between it. So I just say, if the oligoclonal band testing is positive or the IgG index, I treat it the same. And if they are discrepant, I don't interpret it any other way.
Thank you.
Yeah. But what I think will be more interesting, though, is potentially whether we can identify specific signature profiles of oligoclonal bands by using different methodologies as to whether they sit more with one disease versus another.
And if I can make a comment on that, am I allowed to ask a question of Sean? Because there's a comment / a question. So part of this, what we have to remember with all of these testings, whether they be IgG index, which is the crudest, so if we take it through the sequence from crude all the way through Sean's work, which is much more elegant. So the IgG index is, do you have more IgG in your CSF than we expect? Period, full stop. It's a mathematical equation. Oligoclonal banding is there a pattern of IgG synthesis in the CSF that is not represented in the serum in an antigen agnostic way? We have no idea what antibodies are reacting to. We just know the size, the kilodalton size of the antibodies and how they restrict. That's less crude, but it's much more subjective. It's somebody looking at a scan. Then we move into Sean's world, and please edit this if I'm wrong, where at its from crude to fine, we move from, is the antibody staining a cell? If so, what cell? Is it a neuron, an astrocyte? Is it staining the intracellular or extracellular portion? And then ultimately, do we actually have an antigen based on a Western or an ELISA or a transfected cell-based assay of the exact antigen? And that's moving from crude to more fine. But what I would challenge us to think about, and curious about Sean's comments, is just because I have 10 of you staining the transfected kidney cell with NMDA on it, the 10 of you probably have different antibodies all responding and binding to NMDA, and you may have very distinct phenotypes based on the binding or different binding patterns, even though you are all NMDA positive. And I do not think we have gotten good enough in our techniques to get that level of definition, that granular detail, past just antibody positive or negative. But I think it's the next generation of things. What I'm waiting for is to get a report from Sean's lab that says not only are you NMDA positive, but you are binding this epitope in this way, and you have these 10 different NMDA antibodies in relative molar concentrations, and is that clinically meaningful or not? Come on, Sean, hurry up. We're waiting on you.
That's going to be very difficult to do. But I think we can get at that. It's going to be difficult to get at epitope specificity, but you would be able to get at the clonality, the specificity of a clone by using mass spec. But it's interesting, at least what we are finding at the moment, is that those oligoclonal bands are not. So if you take a patient with NMO and you look at the oligoclonal bands, those oligoclonal bands are not specific for acylphorin 4. And actually, it's kind of surprising. You would expect in NMDA, where in some cases it's post-viral, that you would expect that the epitope would be quite restricted, the epitope specificity would be quite restricted. Yet you don't actually see clonal expansion. You don't. So the antibodies are there, you can detect them, but there's not a sudden big whopping clone that you pick up. So unfortunately, it's just it's quite complex. But I think at the moment you just use these are just clues that you incorporate into your clinical evaluation, and you just use them as that.
Good afternoon. Thank you all for your wonderful talks. My question is directed to Dr. Vanderveer about white matter changes in adults. We recently evaluated a 30-year-old black woman, obese, for bilateral disc swelling, but what was perplexing is in the workup of her new onset headaches, she was discovered to have diffuse white matter changes, non-enhancing, predominantly affecting the temporal lobes and the external capsules. Extensive workup was pursued prior to her seeing us, including the Notch3 gene and the genetic test for vanishing white matter disease. The only positive tests, including infectious, inflammatory, CSF, etc., were a heterozygous Notch3 gene mutation that was of unknown significance and elevated ESR. She did not have any other neurologic symptoms besides headache and disc swelling. And ultimately, we thought after reviewing her records that she had two distinct syndromes. One was the white matter changes, and the second was a raised intracranial pressure, pseudotumor cerebral IIH type picture. But to date, there's no definite diagnosis for her white matter abnormalities. And so the question is, do you see adults with completely asymptomatic? If we're separating these two things, that means her white matter abnormalities must have been completely asymptomatic prior to the year before seeing us, where she developed headaches and disc swelling. Thank you.
So of course, in the context of, of papilledema and elevated CSF rate, you'd want to make sure there wasn't an acquired illness. But in answer to your main question, which is, can you have asymptomatic white matter abnormalities? I would say absolutely, because we see patients who, are scanned because they have a car accident, or scanned because they have had migraines for years, and they show up in an ER who finally scans them, and so I would say absolutely, you can have patients who have very, very polysymptomatic white matter changes. Usually if you dig quite a bit and if you really examine them, you might detect a little bit of extrapyramidal features or a little bit of spastic paraparesis, but you can have patients who are remarkably asymptomatic. In particular, if the white matter signal abnormalities are more along the hypomyelination spectrum, the patients can be extraordinarily polysymptomatic. And I think that in response to your question, it might be nice to take a look at that MRI and see if there's a pattern there that comes out relative to some of our known disorders.
when CSF is positive for one oligoclonal band or two oligoclonal band, do you disregard? And also, if elevation of oligoclonal band clinically correlates with severity of symptoms?
So on, everyone should be curious for everyone's comments. So the second question, correlation with severity, the answer I think is no. I think most data says once you have a positive oligoclonal band, which means unmatched bands in the spinal fluid compared to serum, that whether you have 5, 7, or 10, it's just positive and not a clinical correlate. In terms of your first part of the question, how many bands equals positive, it is a lab-specific defined. Some labs rarely will say 2 or more. Most will use 3, 4, or 5 as a cutoff for unmatched bands. But when you get your report, you have to see what the lab uses as their standard in terms of when they got their CLIA certification. So at our lab, it's 5 or more. At some labs, it's 2 or more. And so it begs the question for me, how could there be different standards of positive or negative? There isn't a single lab that says 1 that I'm aware of. So at the lowest I've seen is 2 or more. And I think Mayo is 4 or more for Mayo Clinic. And the Mayo Clinic is always right. So I'd say my answer now is 4 or more is positive. So.
And I just want to emphasize in terms of the oligoclonal band evaluation, the critical importance of who's actually reading it. I know that's been mentioned many times, but I think it's well highlighted in pediatric MS. So the German group, which used a central research lab to evaluate the CSF consistently in all of their potential pediatric MS patients, ended up with a number, I think I'm correct, it was either 95 or 97% of pediatric MS patients in their research lab had positive oligoclonal bands on either their initial CSF or in their hands, they did repeat the CSF at the time of a second event. And so by the time the second event had happened in a child, they were about 95 to 97% positive in this very, very specific research lab. That is not the experience that anybody else has been able to replicate because the CSF is invariably done in clinical labs with people who may read them, and particularly in pediatric hospitals, extremely infrequently. And so, we get about 60% of our pediatric MS patients are positive. And I think others have been as low as 40. I don't really think that the oligoclonal bands are different in Germany than everywhere else in terms of patient likelihood of making oligoclonal bands in peds MS. I think it's the lab. So again, just to reemphasize, it's still a very subjective test.
And what I would stress is this is true for a lot of these tests that we were talking about. If you go and spend a week in Sean with the clinical immunology lab at Mayo, you'll learn this is not just taking a slide, throwing on serum, and seeing if there's a green dot afterwards. There is a tremendous amount of art that goes into the science, which makes some of this very difficult to transport a technology from lab to lab to lab to lab. And in oligoclonal band testing, there's an international guideline on how to do it. It says you take CSF and serum, you separate out IgG and purify it, then you equalize the amount of IgG from the serum, so you dilute the serum, so you have an equal nanograms of IgG from CSF, and then you put it on isoelectric focusing to sort out both the size and the charge. When I called the lab that was doing our oligoclonal bands, wherever you send your test, there's literally a person in the lab. So Cindy is in the lab, and she's the one who does it. So you can call and say, I want to speak to Cindy. And I did this one day when I first moved to Dallas, because I was getting back really funny results. I said, hey, Cindy, it's Dr. Greenberg. I just want to ask you a question. Do you separate out IgG? Oh, yes, absolutely, Dr. Greenberg. We always do that. Do you do isoelectric focusing? Yes, of course we do. Do you make sure that you dilute down the serum to an equal amount? She's like, well, we used to do that, but I've been doing it for so long, I can just eyeball it. And I was like, thank you, Cindy. Click. So depending on what Cindy does in your lab dictates why your results are different than my results. So.
Don't think Cindy's probably still there.
Actually, I think she is.
Any other questions at this point? All right, I'll just comment on a couple things that people asked us in the break. So we didn't talk today about treatment because this is a differential diagnosis discussion, but I did have several questions asking about how we manage pediatric MS, and I thought it might be useful just to make a couple of comments. So currently, in children with confirmed pediatric relapsing remitting MS, we are using the platform interferon and glutathione acetate. And when I say we, I mean International Pediatric MS Study Group Consortia. And we use the interferon and glutathione acetate as frontline therapies. escalating to Tysabri in children with really severe disease. And of course, a lot of people ask about the oral therapies that are currently approved in the US and other countries. There are currently clinical trials ongoing and active for fingolimod and teriflunomide, and soon to be one for BG12. You can access these medicines in the U.S. off-label for children, but most of us are preferring, hopefully, to evaluate these in pediatric patients in the context of clinical trials. Certainly, oral is not safer, and there is a lot of concern about using oral therapies with particularly also even some of the more powerful therapies in anyone, but in children in particular, without a consideration of the timing, their prior exposures, and whether or not they've had certain community-acquired infections and whether they are varicella immune. So there's a lot of complexity to using it, and I guess my one general comment in treating anyone with medications that are as powerful as the therapies that are coming online for MS is that we're really getting into a chemotherapeutic level now that is not that different than some of the oncology level of care, and certainly very much akin to our rheumatology level of complexity. And we didn't train for that in our neurology residencies. So my comment to the people that were asking questions about vaccination status and live vaccines and how you should handle these patients is I really think we should talk to rheumatology and oncology if you're not familiar with how to do this, because you obviously, as a neurologist, may have never been trained in the timing or use of some of these very now increasingly powerful therapies. So that's just a very brief comment. Certainly there are sessions throughout the meeting that are going to be talking a lot more about therapeutics, but several people asked that question, so I thought I'd just share that with the group. Any other comments or questions from anyone else? All right, so taking your feedback then from the process, one will be that we'll have a potpourri of patient cases. We'll mix them up. We'll challenge you to see what you would do and what you think. We'll add that to next year. Please, again, I want to emphasize, do complete your forms and evaluation. We will really use them. And I want to thank all of you for your attention. The opening party tonight starts at 6, and I hope that you'll be at NeuroBowl as well. Thank you all for coming.